Evening and good afternoon. It is a pleasure to welcome you to the presentation of the document on course of life, concepts, implications, and implementation on public health. Fernando is going to share with us the instructions. Today we have interpretation into three languages, Spanish, English, and Portuguese. In the lower part of your screen, you will see there is an icon which looks like a globe. If you click on it, you will be able to see the available languages. And if you click once again, you will be able to listen to simultaneous interpretation. We will have a chat, and my colleagues will try to reply to any questions or comments you may have regarding the document. This is an informative webinar. We will have no questions and answer session because of the time limitations, but we will try to reply to your questions via the chat. Before starting, I would like to thank all of those who have participated in the preparation of this document and those who have been part of the project. We have had several technical advisors and professionals in several areas of the organization. In this process, we had the support of the Academy of External Advisors in order to prepare this document. I would also like to mention and very especially thank somebody who was very beloved in the organization, a colleague and friend of several years, Dr. Manuel Peña, who unfortunately is no longer with us. Dr. Peña was a regional advisor and representative of the organization for several years. And for us, he was a highly respected professional. He would have certainly been very happy to see that this document has been published. The program that we have for today, which our colleague Fernando is sharing, will start with the opening speech of our Assistant Director, Dr. Jarbas Barbosa, followed by Dr. Enrique Vega, who will present this document. After that, we will hear our special guests, the Minister of Health of Guyana, Dr. Frank Christoph Stanislaus Anthony, and Dr. Anshu Banerjee, Director of the Maternal Health World Organization. We will also have two technical panels. The first one will be about this new focus on the course of life and how will this affect the way we carry out our public health programs. And we shall listen to technical experts of the organization, Dr. Hernan Luque, Dr. Juan Carlos Silva, and Dr. Patricia Solis, and Engineer Ramon Martinez. The second panel will be on national experiences and the contribution on course of life in order to improve public health for everybody at all ages. And it will be moderated by Dr. Amalia Yala, who is an advisor in Guatemala. We will have the participation of Dr. Gustavo Rossell, Minister of Health of Peru, and Nurse Leighton Cardenas from the Subsecretariat of Public Health from Chile. In order to close this event, we will listen to Dr. Andres de Francisco, who is the director of the Department of Family, Health Promotion, and Course of Life. Without further ado, I invite you to listen to Dr. Jarvas Barbosa. Distinguished representative of the Pan American Health Organization, representatives from the countries and focal points, distinguished colleagues from the PAHO and the WHO. Good day. Welcome. It is a pleasure for me to welcome you in the launch of the document Constructing Health Through the Course of Life, Concepts and Implementation and Application. Thank you to all of you for sharing this moment and for sharing this optimistic and new way to put the health of persons as an essential element for progress in mankind. In the region of the Americas, we have had substantial progress in life expectancy at levels which were never seen before in the history of mankind. Technological and social development has been much faster during this last generation. These technological and demographic change have shown that there is a change in where people live and how we practice public health policies. This requires innovation and new concepts, so we are not only preventing health, we must go beyond this. We need to consider that health is a resource for people and generations in order to add value to the societies and the people of our societies. This concept, which is a new concept, will provide new practices to observe health in a dynamic way whereby we can learn that this resources and the capacity which we call health requires to be built and maintained throughout life. And what we are doing or what we do not do in order to build this resource will later on have influence in our path. This document about this path of health has a clear and decisive influence on the development of mankind. The text is especially important when we try to see how we will make progress in the health network of the region and how to reduce the gap between life expectancy and the expectancy of a healthy life, which is one of our greatest challenges. When we can extend life expectancy, but we have not been able to make sure that the additional years are healthy years, the repercussions of this course on life is based on scientific knowledge and of the evidence obtained throughout decades of research, and also on the importance of inserting health in governance processes which are focused on development. Let us hope that the concepts that this document contains will help to promote the vision of the need of a multi-sectoral integration in health. The focus on course of life, as it is presented in the document, brings a model which can contribute in an especially important way in our fight against inequity in health. And the influence of this lack of equity are not only transcendental elements in the course of diseases, but they also participate in poor health paths, which in turn are important because they affect general development. It also helps us to understand how these bad or poor health paths can trans- be translated from generation to generation, and this focus will help us to find strategies that protect health and development during critical moments and will give priority to the health path of those who were left behind at some point in time. Distinguished colleagues, in this difficult time for the world, and especially for our region, we have learned many lessons thanks to the COVID 19 pandemic. Several lessons are related to the basic principles of the course of life, which you will find in this document. We hope that this publication, which is the result of a joint effort of specialists from this organization, will contribute to your work in public health in our countries and will help to focus on multi-sectoral efforts centered amongst people and populations in order to obtain an equitable progress in the objectives and the SDGs. The real value of this resource is that it should be implemented and translated into concrete actions at the regional and local level in order to improve well being and health for everybody at all ages. Thank you. As Dr. Barbosa said, we hope that this document will be useful for the countries of the region and will be translated into concrete actions which will help improve the health and well being of our population. We will now listen to Dr. Enrique Vega. Dr. Vega, please, you have the floor. Good morning. Thank you very much for the opportunity and for being here with us to share the launching of this technical document to build health during life course. It has been an important effort carried out by a group of professionals of the organization, of academia, who have helped us to develop this project. As Carolina mentioned, I also want to praise Dr. Manuel Peña Escobar, who was an example of a scientific, inquisitive mind, and he was constantly working in order to find new processes to close gaps of inequity. We owe Don Manuel a lot because he built this concept in order to unify our concerns and the work we have shared during many years. We want to share our respect for the work of Dr. Manuel Peña. Any document that tries to discuss the course of life, we have talked about this many times, but we need to insist today. Why are we doing it? Because we are going through a revolution as far as longevity goes. More than ever, life expectancy has increased in the past century. It has increased by 30 years. The previous expansion was for 20 years, and many centuries had to go by before mankind, in the past 60 or 70 years, life expectancy increased by 30 years. This has had many consequences at the social, anthropological, demographic level in modern society. The generation in the different stages of life have been very important. We have more than 5 generations living on the planet at the same time, sharing the planet in a very special way, to say it like with those words. And therefore, the challenges have increased when we're trying to develop a health strategy in this environment. Not only life expectancy has increased, unfortunately, the increase in life expectancy has been shared by another increase, which is the gap in health. We live for many more years, but these additional years are added with life without good health, which in turn means that the relationship between people and health services has increased, and many of the solutions that we have found in order to reduce mortality and to improve our results are not results that we can find as far as the diseases or complications related to diseases that appear at old age. Many infectious diseases have become chronic diseases. HIV, for instance, have a very similar life expectancy when the adequate therapeutic is not in place. and the life expectancy of people who are not these. And there are other non-communicable diseases which are chronic, and therefore one of the greatest challenges that mankind faces now is chronic diseases. And of course, we have the need of a new vision to include health in the development agenda. And that construction of that vision for health, which should be innovative, should be acceptable in the path to development, requires a new vision. And of course, we have also learned a lot. Information and the capacity of knowledge that we have today has been multiplied across all that it has, and the influence of several factors that have occurred early in life uh, on the later part of life. What does this document bring? It has three main components. First of all, we try to summarize and include what is should be pleasant reading, concepts, definitions, and some methodological tools in order to create a framework for this course of life, to show clearly the dynamic influence that it has with what happened in the early stages of life and the mechanisms who are positive or negative influences that occur during our life form the human path and social development and have a very important effect on the individual and collective health. Within this concept, the document mentions important issues. For instance, the vision of health as a resource and as a human capacity. I believe that that should be a fundamental step if we wish to build a vision based on the concept of course of life. Stop seeing that health is something separate. Health should not be considered as a state or stage. It should not be considered as something that is granted and that is lost throughout the course of life. Health is a space, it is a budgetary space which we get through our genetic heritage, but it requires work throughout life in order not only to develop or avoid disease, to develop a healthy life, but it is also an important element for human beings. Is somehow measured in the document, and the document highlights the importance of events, not only disease, but also the development of this capacity and the effectiveness of intervention, and it shows a dynamic vision of critical moments in life, and it also highlights that the clear vision and the social elements that determine this, there is an effort that has to be developed and built in the framework of life. Last, something that is related to what our assistant director said, something that is related to the interaction between the lives of different people. In the text, we are also indicating the repercussions that the focus of course of life in public health. It is a model to be included in the development platform, and the necessary changes in the way we examine and approach the epidemiological reality of our country, the need for an active and dynamic vision of the effect of the causes and effects of epidemiological events. It also has to do with the design and the program in health. Today, in some of the panels, we shall see what is their influence in the work of sanitary services or health services and the role it must have in the measurement and research on health and on the training of human resources, and of course, its influence on the development of ethical support for health. This document also speaks about the elements that are already included in many programs that you already know, programs with which we are working today, which are obviously under the influence of the course of life. Some of them, for instance, the nurturing care for early childhood development, the transition and positive development to teenagers, immunization, the work, gray zones within the public health, for instance, the health of men, and the development of the strategy and the philosophy around a healthy aging processes. And all this has been included in the document. The document tries to find some philosophical and scientific synergy between all these documents, trying to have an integrated vision of the person. In other words, the document seeks to develop a new vision that will allow us to face the changing environment in public health and will allow us to look for a vision that is not only taking care of diseases, but will consider health from a new point of view with the highest development level possible in order to develop health for all. Thank you. Thank you so much, Dr. Vega. That was excellent. This is what you will find in the document, especially the vision of health from the life course perspective. I now will give the floor to our first special guest, the Minister of Health of Guyana, Frank Christopher Stanislaus. You have the floor.
Thank you very much, Madam Chair. Distinguished ladies and gentlemen, allow me to thank PAHO WHO for the opportunity to make a few remarks at this webinar on the life course approach. As humans, we are in a constant quest to understand our biology and to develop strategies to stay healthy and live long and enriched lives. Over the years, different theories and techniques have been postulated, tested, refuted, and many accepted, leading to an expansion of our understanding of how we, as humans, can stay healthy. One such pathway has been the life course approach, which conceptualizes health as reflecting an underlying developmental trajectory from preconception, conception, childhood, adulthood, and ultimately aging. The pathway is multidimensional and is affected by biological, psychological, behavioral, and social factors. The interplay of these factors can result in positive or negative outcomes as individuals develop and grow along this continuum. What health means, therefore, varies depending on the position on this developmental trajectory. The life course approach to health has been long postulated and has been used to elucidate causal connections, how factors in one period of life can influence and impact a later period in life. Understanding these connections allow us to devise policies and programs to reduce the negative consequences of some of these factors and to ensure that we attenuate the positive impacts. Over the last few decades, researchers used this methodology to advance our understanding of many aspects of health and has applied it to bring specific improvements in many areas. And if we look at the life course, we can see many ways of how this has been applied. So one of the troubling problems in our region, for example, is that of infant mortality. And we know, for example, that the leading reasons for infant mortality would be prematurity, low birth weights. In other examples, it can be respiratory distress, congenital anomalies, infant deaths, accidents, or pneumonia. And if we take just one of those, low birth weight, we see that low birth weight can later on lead to natal mortality. So in morbidity is developmental delay, increased learning disabilities, and in later, when these babies develop into adults, it can also lead to chronic diseases. And to prevent this, we can adopt various models. We can intervene early to prevent many of these outcomes that we are seeing. And this is just one little way in which we can adopt this methodology in our various programs. I'm sure that during your ensuing discussions on the life course approach, that we'll look at many of these areas of transitions, the trajectories, and the turning points. And we'll perhaps be able to elucidate the secrets of health and longevity. With this new document, I hope that building health throughout the life course concepts, implications, and applications will help us to bridge the gap between theory and practice. I commend the authors, and I look forward to us using this document and inculcate it into. I wish you all well in your endeavors. Thank you so much.
Muchísimas gracias, señor ministro, por sus palabras.
Thank you very much, Mr. Minister, for your words and to speak about the relationship between the focus of course of life with some examples. I will now give the floor to Dr. Anju Banerjee, special guest from WHO.
Thank you very much, and it's really a pleasure to be part of this important event. Let me just put up a few slides, and I hope you're able to see the slides. First of all, I want to congratulate really our colleagues in PAHO on its leadership in this area and on the excellent report that will undoubtedly become a key reference as it translates technical research language on life course and communicates it to those who can change systems. As the director of WHO's Maternal, Newborn, Child and Adolescent Health and Aging Department, the main messages are central to our common goal of building health across the life course. The report stresses fostering health and well-being, not only addressing disease, which is very important. This is expressed in different ways, from ensuring that children thrive, addressing critical transitions such as from adolescents to adults, going to ensuring that older people's abilities that enable people to reach their potential with equal opportunity and can do what they value are addressed. I'd like to make a few general comments and then reflect on some of the implications of this report. First of all, a comment on the life course concepts. The report lays out life course concepts in a clear and comprehensive manner and also presents a wide range of implications, including for shaping health system functions and progress towards universal health coverage. We do need to support changes in health behaviors that combine motivating youth and adults and improving the social determinants of health. As noted in the report, the space between younger and older adults deserves more attention, and that does not, for example, simply reduce women's health to reproductive health or men's health to only addressing non-communicable diseases. For example, while aspects of adolescent health are related to the cumulative effects of health during childhood, adolescence is also a time of great change and thus great potential with regards to strengthening intrinsic. An estimated 70% of preventable deaths from non-communicable diseases in adults have been linked to the health risks and behaviors commonly established in adolescence, including tobacco, physical inactivity. Tobacco in adolescence contributes to increase for non-communicable life. Yet evidence from adolescence is a unique opportunity to shape neural development, early intervention in this age. Another message that is coming out is the need, and also just highlighted around adolescence, is the need to intervene to construct and in general achieve healthy life trajectories. If we step back to the development theory, how mental exposures and social experiences, especially during sensitive periods in life, are integrated into biological and behavioral systems. For example, WHO, UNICEF, and the World Bank are collaborating on the measurement of children's development from birth through to 8 years old to really see how we can properly monitor their development. Ensuring children are thriving is a precondition to ensure the cumulative benefits of a life course. In fact, and before conception can have long-lasting impact on the health of the child. And I think that His Excellency, the Minister from Guyana, actually gave a wonderful example about that just now. In relation to healthy aging, interventions that enhance reserves as early as possible, that delay decline in health and persons, and that slow down the rate of declines need to reach people. There's also a message around multi-sectoral partnership. This report also sets out that building health through the life course requires the health sector and multiple other sectors to work together. Putting people at the center and developing healthy life trajectories requires person-centered approaches in relation to their changing environments. In the health system, this includes coordinated and integrated care, and reflecting and respecting the goals of individuals. But the life course is also a powerful approach for overall development that should help connect different silos and different sectors, such as health, education, labor, welfare, and others. Maybe I can reflect a bit on strategic implications coming out of the report. I would like to consider how we can support ministries of health and other ministries in taking the implications or recommendations forward, recognizing that the health of every population group must be considered as equally important, which is one of the lessons that we have learned from the COVID pandemic that so far has mainly affected older people disproportionately. A life course approach helps optimize people's health and well-being at all ages. It recognizes the health concerns of different stages of life and ages, thereby helping to address health equity and gender equality as well. To do so, it must be grounded in internationally recognized human rights standards, as they provide both the normative and legal foundation. These human rights standards are relevant for all stages, for all life stages and transitions. For example, the right to information is as relevant for children and adolescents as it is for adults and older persons. How it is implemented will be different for different life stages, whether taking into consideration children's evolving capacity, people's literacy levels, or fostering older persons' abilities, even though they may have declining capacities. I'd like to share two thoughts. First, there are many countries converting disease-based health and public health policies or disease-based health systems to a life course approach. For example, looking outside of the PAHO region, over the past few years, Qatar's national public health strategy was developed to take a life course approach. The country wants to adopt best practices as part of its intent to benchmark improvements in the country against global benchmarks. They realized a life course approach is appealing not only conceptually, but in practice, and they believe it is an innovation that will result in better health at all ages. And finally, a second strategic implication is our dialogue with our development partners. The report encourages that if we think differently using a life course approach, we also have to act differently. And the report points out that investments are needed that consider early actions, linkages to critical and sensitive transitions and periods of life, and a whole of society approach, and that there's still a need for additional research and additional evidence that is needed to take this forward. Thank you very much.
Muchas gracias, Dr. Banerjee.
Thank you, Dr. Banerjee. We truly appreciate your comments regarding the document, very specific, very relevant in a number of areas, especially important coming from you with your vast experience in this topic. Let me now invite Dr. Sonja Café. She will be introducing the next session. Sonia, you have the microphone.
And good day to everybody. It is really an honor to be part of this important event. As we heard from the previous speakers, the life course perspective supports the construction of healthy trajectories for individuals, families, and communities. At the same time, the life course approach also supports the development of health systems and responses to health that have a focus on the individual and on an integrated approach and human-centered approach to reduce these inequities and transform opportunities It also invites us to consider that a life course approach, sorry, helps us reduce missed opportunities and to shorten and reduce gray areas in our approaches. In this way, we can contribute to making sure that all individuals, groups, and communities that none are left behind, and that all have equal opportunities for health and development. In this context, the life course approach is not only critically important for those working on the health of women, children, and adolescents, but definitely from every public health approach, we need to consider what the implications are for a life course approach. It is therefore an honor and a pleasure for me to introduce the next panel of PAHO colleagues who will be making brief presentations on implications of the life course approach from different angles. First, we will listen to Herman Luque, who is an advisor in health systems and services, who will make a presentation about the implications of a life course approach for the provision of people-centered care on the first level of care. After that, we will listen to Juan Carlos Silva, retired advisor, regional advisor in visual and auditive health, who will make a presentation about the importance of assets across the life course. And finally, we will be listening to Patricia Solis, who is advisor in health analysis and equity metrics, who will make a presentation prepared together with Ramon Martinez from the Department of Non-Communicable Diseases and Mental Health about the dynamics of the epidemiological transition and the evolution of burden of disease across the life course. Colleagues, thank you very much for your participation today. You each have 9 minutes to make your presentations. Please, Hernan, the floor is yours. We are listening to you.
Thank you very much, Sonia, and good morning to everyone, both panelists and health authorities and professionals who are interested in this topic. It is truly a challenge for health systems. I'd like to share with you a brief presentation, so I'm going to share screen with you. Hopefully it can be seen clearly. Yes, but perhaps you could switch it to presentation mode instead of just your screen. Is that better?
Yes. Adelante.
Yes, it is. Very well. I'd like to briefly talk about the implication contained in the document that we should be looking at closely. It is a life course document, something that has been long awaited by countries to try to understand and more clearly understand the approach and how this approach can be adapted and implemented in our countries and in particular to manage health services. First, when we look at health service policies and services, the definition of the model in each country plays an important role in each country. The model is, after all, the health vision that is sought by the country and its society. Furthermore, the organization of the services and the delivery of health services to guarantee an approach and movement towards that vision with financing, with regulations, with policies, and a service management that is aimed at achieving these targets, these health objectives that are defined within the care model. From this perspective, the life course approach is a different approach to health compared to what we've had thus far. It is often understood as indicating that the essential role of health services is to tackle disease. However, today we know that disease is only a consequence of a chain of prior events that trigger a morbid process. And this obviously has an impact, and thus the life course approach truly explains this process of developing from health towards disease. Now, why are we looking at this as a different approach? Well, because it focuses on developing peoples and populations and families' capacities. That is at the core. It is a novel idea from the perspective of health services. To give priority of to these interventions that promote and develop the empowerment by people and the communities in their capacity, this intrinsic functional capacity of people. This is for us a vision where healthcare models at the country level should devote a special approach. It's no longer looking at risk and disease only. Without this vision, we have always asked, what is health? What is the development of health in people? To a large extent, developing health depends on developing these intrinsic and functional capacities of individuals. And they are actually well described in the document that is being launched today. And I invite you all to look at it very carefully. And then the document introduces this figure. The purpose is to reformulate the organization of healthcare services throughout the life course, ensuring through service management, focusing on an integrated delivery of services organized in a network that will support an individual from conception to old age. In other words, at each step of development and satisfying and meeting the needs of the individuals. Moreover, it also requires that it is necessary to socially and sectorally coordinate with other players who are fundamental to respond to the needs of persons, families, and communities, and obviously having an impact on health determinants. From this standpoint, there are 4 aspects that we believe are extremely important. The life course focus or approach ties into service models that are actually centered on persons, families, and communities. This means that we need to know the people, the family, the context of the environment, the conditions of life, study, work, and leisure. It also implies to know the profile, not only about the disease and the risk of the person, but the profile of their health throughout their life course, and empowering people in regards to their own health. It means integrated and integral care of individuals in order to coordinate health services of different natures, in order to address the needs of each person when it comes to their health. In other words, the person has to be viewed not only holistically, but also respond to their health needs, not only the diabetic because he's or she is diabetic, but because there are other needs that go beyond simply caring for the diabetes. Health services are organized in integrated service networks. This is vital in the model to overcome the existing fragmentation of health services, deliver services in an integrated manner that would include health and other players, as we mentioned earlier, so that all of these social sectors within a territory may be coordinated and complement one another in a harmonious manner in an integrated network, and a primary care level that is strengthened. The cornerstone of the healthcare network is the primary level, the primary care. And at this point, develop capacities to strengthen supporting individuals and their families, meeting their needs and their life course and their demand for service. All of this plays an important role as the first level or primary level of care is, after all, a contact with services throughout the life course that is closest to persons, that can strengthen, promote, and stimulate their capacities. So in a summarized manner, we are trying to urge all participants today to read this document, to study it, because it is an extremely important document. And from the standpoint of healthcare, it actually makes us see a new approach of organizing health services in networks and thus strengthening the life course in our countries. Thank you very much.
Thank you, Hernan. And we now move to Juan Carlos. The floor is yours.
Bueno, muchas gracias, Sonia.
Thank you very much, Sonia. And let me thank everyone for the invitation. My issue will refer to the assets in the life course. As previous speakers have pointed out, we had a blank, we are born as a blank page, and we acquire strengths and skills throughout our lives, and that is crucial to our lives. There are two fundamental issues. One is the functional ability that we have. Basically, this is the intrinsic capacity with regards to our environment. In a bad environment, it's not as easy to develop, but with low intrinsic capacities, one cannot develop well either. The approach now is not simply disease, but how to develop functional abilities in individuals from prior to their birth practically, because this actually has to begin during pregnancy and continue on to the end of life. So that is fundamental. One can also intervene in environment, but also in the intrinsic capacities, and that's what I'd like to focus upon now. Now, what are these? Well, it's mobility, cognition, psychological and sensory capacities. These are areas where we can intervene, especially through the health systems. All life events contribute to life health trajectories, or actually the trajectory of life itself. It's not only about health, but about our lives of people. And by providing support and care, we can, there has to be an environment supporting this development. Normally, the intrinsic capacity as well as functional are developed during childhood and then they grow. Obviously, it depends on the surrounding conditions, and it goes towards adulthood. Now, we see this green arrow here. What we need to encourage is for the green arrow to grow, but the red arrow to decrease. In other words, to gain more at the beginning and lose less at the end of life. Looking at the intrinsic functional capacities at the beginning of life can also predict to a certain extent how functional we will be towards the end of life. As we develop more capacities in early life, more functional capacities will continue existing towards end. But it obviously depends on the environment and support and services received during life. So this issue of intrinsic capacity is very important because we are changing our health focus from acute disease and chronic conditions to functional capacities. So it is not simply a matter of curing the acute and chronic situation, but manage, prevent, and promote functionality. To do this, we need to monitor the life course of individuals in their functional capacities, as well as the intrinsic and functional capacities. So there are several things that we can do through public health, and it is to evaluate the functional capacity of persons, identify risk factors and dependence, because especially in older adults, we need to see and identify and tackle the problems and risk factors for care dependency, and obviously develop and prevent or reverse declines in functional capacity. And as Hernan pointed out, these are interventions that hopefully, and in as far as possible, will be voluntary, because it is, after all, essential to create an environment for people that should not only be at the primary care level, but it should be interdisciplinary. In other words, interacting with other health elements and other intersectoral elements in addition. This is a graph. I'm afraid it's not good quality because I copied it from the article that is mentioned at the foot of the slide, but it describes the life course having to do with health, nutrition, security, and safety. And this applies both to children and adults, and the care they receive. And lastly, learning. These are the core elements. Now, we are focused essentially on these two, but we also need to ensure that there is security, that there is good care provided. Furthermore, early learning and learning throughout the life. Today, I continue to study, to learn. Now, here we can see the difference between children and adults. Once again, as there is a drop in children under the age of 5, we are starting to increase the potential for the development of these children. It's not only the disease, but how can we ensure that they develop better?
And this, of course, is supported by global strategy for women's, children's, and adolescents' health. In healthy aging, we have, for instance, once again, the intrinsic capacities, the socioeconomic environment, and the physical environment. And as an example, I here show what ICOPE proposes to screen IC declines or deficiencies, the primary health care, in order to assess the functional capacity. We also need to have a referral pathway and the community which must support the person. This refers to adults mainly. There are three important elements. One is the functions monitoring, the geriatric assessment, and traditional clinic. I will not make a list of these because you all know them. This is only the assessment and this is the plan. In the plan, as well as in the assessment, we have the three lines. These are the traditional ones. And this is the new one, the new vision that we have, which it's not only the two that we used to have, but the functions monitoring and the multidimensional programs, which are essential for people to maintain or develop their abilities as far as mobility, vitality, psychosocial development, sensory and cognitive active. So this left column is the one you need to look at. I am now going to talk about my subject matters. Mine have been related to sensory impairments. The issue is not whether a person can see or not. Vision impairment and hearing impairment are linked to other elements. These are supported by studies. I did not put the references because the references would be too long. All these elements have been studied, but they have to do with the psychological aspect. The falls, for instance, which are more frequent, physical activity, social engagement, and there are some studies that say that those who not have good vision retire early. As far as hearing impairment, people are more isolated, they are more likely to have anxiety and depression, and there is also a cognitive decline. There is a cognitive decline for people who are hearing impaired, senile dementia, and so forth. We have, I skipped a slide, I don't know how to go back. There are several elements during the course of life which must be taken into account. Not all people have the same determinants. Some people have different determinants for the decline or for their life trajectory. For instance, the Caribbean people have a higher prevalence of some diseases, for instance, glaucoma. If we monitor whether the functional capacity of people decline in the Caribbean, we would also have to think about this type of element. And the same happens with those who have diseases. For instance, diabetes. Life course of people with diabetes is different, so we have to think about that element. This is important. This slide here is very important. It shows us that newborns who have retinopathy of the newborn ROP. I know that it doesn't happen in all hospitals, but it does happen in some regional hospitals because we have not been able to establish standards. These children are going to be blind, but not only blind, but they're going to have a cognitive decline, which has also been proved with very serious studies. In the case of hearing health, children who have a deficiency up to 5 per thousand, they have a different life course if they have a hearing impairment. With teenagers, we see that they will develop these problems during course of life, and this makes us think about the increases in noise. And for older adults, we have to do visual screening. So this is what I wanted to present to you, and I thank you very much for your kind attentions.
Juan Carlos, and now we invite Patricia Solis.
Buenos días, gracias. ¿Ven la presentación?
Good morning. Do you see the presentation? Yes, we do, but we don't see it in presentation mode. Thank you very much. I am going to share with you a brief but very important session on the epidemiological and demographic transition and the shift of disease burden throughout the life course in selected countries of the Americas from 1990 to the 2000. It is important to mention that the data that we're using come from the Global Burden of Disease study prepared by the Metrics Institute of the University of Washington. We are basically working with two main indicators. First of all, the socio-demographic index, which is a synthetic index that includes income, education level, and fertility. And the other important indicator is related to the result of burden of disease measured as a disability-adjusted life years, which in English are known as DALYs. And the importance of the use of DALY is that it allows us to see the number of years that are lost due to a premature death and the years lived with a handicap. In order to see the situation in our countries, you will see here the countries based on their level in 2019. If the value is closer to 1, that means that the development index is to the right, it is higher. And we have countries such as Canada, United States, which are on the top of the graphic. In Canada, 0.87, and we also see this heterogeneous composition for our countries. We still have countries that have values that are below 0.5, such as Nicaragua, Honduras, and Haiti. But in this visual slide, you can also see the change that has occurred since 1990. 1990 is the value that is on the left, related to the value on the right, which is for 2019. So Guatemala had a change of from 0.31 to 0.52 in 2019. So this happened over a period of 30 years. In order to speak about the burden of disease throughout the life course, in the current slide, you will see what happens with the region. At the top left corner, you have the graphic of the contribution of DALYs per age groups. In blue, you have the data for 1990, and in dark pink, you have the data related to 2019. In our region, in 1990, the greatest contribution for DALYs was for children below age 5, and this went down to less than 10%. But in addition to this, there has also been a shift in 2019 with the proportionate contribution of DALIs of groups which start at age 45 as compared to what happened in 1990. On the right-hand side of the slide, we have the DALI rates per 100,000 population by age, and what we can see is that there is a decrease of the rate in 2019 compared to the value for each age group in 1990. Unfortunately, the voice of the speaker is breaking up and the interpreter cannot hear her. The first group is highlighted with the red. It's group 1, which includes communicable diseases and maternal problems. The blue represent group 2, non-communicable diseases, and green is external causes. In 1990, for each of these age groups, the three groups were present, but the communicable diseases were more important for minors, and then we saw the most important of non-communicable diseases for older groups and external causes, which are usually present in younger groups. As far as rates for important causes, the non-communicable disease has the highest rate, but it also has an important element in DALIs for non-communicable diseases. Let us export the situation in a country such as Canada, which had a high socio-demographic index in the region, the highest in the region. And with regard of the percentage of DALIs per age, in 1990, the group of age 5 or less only contributed to 5%, whereas in the region it was close to 25%. In 2019, this has decreased, and we see that this shift in the proportion to other age groups in Canada as of 2050 in 2019. The DALI rate also decreases in all age groups, and in as far as important causes of disease and DALIs, non-communicable diseases in 1990 were very important, and this is much more clear in 2019. And this is what you can see in the specific rate for each group, age, and cause. And now I will show you the case of Guatemala, where we saw an important increase in the index of social demographic development, and which in 1990 Guatemala would contribute with almost 50% of DALIs. There has been a very important decrease in 2019, less than 19%, but we can also see once again this shift in 2019 of the burden per year of DALIs after the age of 15. The DALIs decreases in all groups except for the group of 95 and older, and different from what happens in Canada. In 1990, the burden of group 1 of communicable diseases was more present in each age group, but in 2019 we also see an important shift and an important decrease in the growth of non-communicable diseases and external causes, which generally generate more DALIs. In the rates, different age groups are generally generated by group 2, the non-communicable diseases, but what is more important is the rate for the age 0 to 5. This only happens in some countries. We know that our region is different, and we will try to examine what happens to Brazil.
The pattern is similar to the rest of the region when it comes to movement of the proportional contribution of DALIs in, I think it was from starting at the age 35 in 2019. But this is only an exploratory analysis of the first level. If it were a subnational analysis, we would see greater differences because we know that our countries are different within the country. To conclude, I'd like to show two countries where we found two different results, different to the rest of the countries. These are Honduras and Nicaragua. As you can see in the upper right of this slide, contrary to the previous case, in Honduras, there is a DALI increase in 2019 and not a decrease. This increase begins at age 55. And now moving to Nicaragua, that increase can be noted starting at the age of 65, and that is a pattern different to the other countries in the region. So what conclusions were we able to draw? Well, all our countries are going through a substantial demographic transition with a characteristic aging. All my colleagues have mentioned this, and it needs to be taken into account in performing these analyses. And this has more to do with the change and progress of all socio-demographic elements. These cannot be neglected. The epidemiological transition that shows an important weight of non-communicable, but there is this competition with the cause, with the item one, external causes. Guatemala, for instance, had an accelerated transition over 30 years, and there was an important change in the demographic index. And then there are what we've seen in Honduras and Nicaragua due to the increase of DALIs in adults, in particular older adults as compared to other countries. Our countries have a double burden. This is a challenge for the health system, and my colleagues spoke at length about that topic and the items to be taken into account. Lastly, we do believe it is important to always use demographic and epidemiological analysis as useful tools to define priorities, and all the more so with the life course approach. Thank you very much.
Thank you very much, Hernan, Juan Carlos, and Patricia, for your excellent presentations. You gave us much food for thought. I just want to highlight the example of the presentation of Patricia, where she illustrated with the DALIs how data can help us better understand the tendencies not only of mortality, but of health and ill health within countries and between countries. Hernan and Juan Carlos had two key words, capacity, the importance of capacity in the building of health, the construction of healthy trajectories. And I think Hernan emphasized the importance of the health system to not only address disease, but to build capacity for better health, and how the implications of that for the organization or reorganization of health systems and health services for prioritization and investments. Thank you, all three of you, very much. And now I give back to Carolina for the final panel of today.
Muchas gracias, Sonia. Excelente panel.
Thank you very much, Sonia. An excellent panel, and thank you, panelists. Let me now invite Dr. Amalia Ayala, who will introduce the next panel. Dr. Ayala, please go ahead. Thank you very much. Thank you also for inviting me to be the moderator for this panel, and that how the life course is contributing to improve the health at all ages. We will be hearing national experiences now. Before introducing the panelists, I would like to underscore three important aspects that should be included in the life course approach according to what we can see in the document being launched today. First, use of the life course approach by ministries of health guides and facilitates better integration and articulation of programs to deliver health services and to have a better and greater integration for the health of people, families, and communities. This approach, moreover, as we heard previously, makes encourages multi-sectoral approaches. The ministries of health will convene different sectors to address social determinants of health. The concept of development to improve the quality of life of populations, indicators for monitoring, as well as efficient use of resources. Lastly, the document indicates that the life course approach can be used as a useful tool by community at the primary level of care and integrated health network, situating the person at the core and at the center of all interventions, focusing on integral, integrated, and continuous care, as well as the care of families and communities. This person-centered delivery cannot be provided through vertical programs that are fragmented or offering services that are isolated. I now introduce two distinguished representatives of ministries. First, Dr. Gustavo Rossell, Vice Minister for Health in Peru, and Nurse Barbara Leighton Cardenas, Head of the Vital Cycle Department of the Public Health Undersecretariat of the Ministry of Health, Chile. With that, I'd like to offer the floor to Dr. Gustavo Rossell, Health Vice Minister for Peru. Good morning and good afternoon and greetings from Peru. I'd like to share with you a short presentation of how we have incorporated the life course concept in our integral health care model focused on the person, family, and community. We have some experience now concerning the integral care model, but nonetheless, it needs to be adapted to the circumstances we are currently living, not only in the country, but throughout the world. A number of times we have heard about demographic transition, epidemiological transition, the great inequities in our countries throughout the region, changes in expectations with greater pressure from young people as to some specific needs, as well as the negative consequences of some models that have caused harm, especially to the most vulnerable. This reality, however, has been overcome with the pandemic we are currently suffering, and this has been going on throughout the world in the past year. So this leads us to think about the importance of the life course model and see that its virtues can also tackle these complex situations for which we were actually not well prepared. Obviously, we have health indicators in the country. We are taking hold now some situations such as malnutrition, child anemia, and vaccination coverage also. Now, this has been impacted very seriously, and that's why we need to revisit our strategies and look at all our interventions. On the other hand, I think for the very first time in history, we have 5 generations with different life experiences, different needs, different ways to communicate. So given this epidemic, we have had to react, taking into account that persons have different needs. The model prior to the epidemic adapted instruments and interventions to provide care not only for the life course, but also looking at the characteristics of each population. In our country, Peru, we have 47 indigenous languages, we have different cosmovisions, and obviously our model has to reach out to people, adapting to their way of thinking, their way of life, and most importantly, how they feel with regards to health. Many of our systems are fragmented with different financing, affiliations, and delivery of health services. So people don't have access to high quality service. And the system, in addition, is anomalous because it doesn't globally respond neither to individual nor collective needs. On the other hand, we also know that a lot of our health services, even prior to the epidemic, were overrun with lack of human resources. But now with the epidemic, this gap has further deepened and the system hasn't had the capacity to respond to the situation. So as a model, and I think we all believe this is an important strategy, and that is to focus on the first level of health, from conception to the last days of life, by looking at the individual and collective responsibility. And these are not issues having to do with disease, but health. This is a concept that has been mentioned because it's so important to human development. So we have a national health policy in the country, and focusing on the integral care throughout the life course and integrated healthcare services. This is a path. You cannot change overnight and have the ideal network or even a model, but this is a social construction that is done gradually involving different players. Our integral cares, and these are actions and interventions, but essentially a way of living these personal cares, and at the community level seek the well-being development of people, their families, and the community. It's not only to promote and preserve. These are important, but also it is a matter of strengthening families, individuals, and looking at their biopsychosocial development. Without going too deep into the model, it does incorporate these elements. It starts from a person and it gradually involves different players to finally achieve an integral system for the development, but most importantly, to care of needs in each of the areas throughout the country. This model was developed thinking that although people are in touch with the healthcare services, most of their life is spent in their home, in schools, workplace, and different areas and spaces. So a model of this kind cannot be based on health services. What we have to look at is services that are present where people live, and especially where they have the most important events of their life. Protect the birth, to have a correct introduction to school and to work. So one shouldn't be focusing on the illnesses themselves, but how we can provide these development tools to individuals starting at schools. And we also have community mental care with centers that don't focus only on pathologies, but it allows people to find and respond to overcome their daily problems. Some principles that are familiar to us, but they are substantial, and they allow us to adapt the model and to include 4 models: delivery, management, organization, and financing. It all turns around the family, the person, the family, and the community. Health services help people to live their lives in the best way possible, but we have to develop a support apparatus so that each person may make the most of their life course, and it needs to be a healthy life course. Very briefly, I'd like to show you that for each life course component, what we want is for individuals to find answers to their situations. Here we have a pregnant woman, for instance. The family has to be educated so the family can also understand about paternity and maternity. And likewise, in each of what we used to call the steps or the phases, but now it's a course, it is sequential, it doesn't have any gaps. So we just transit smoothly from the different phases, providing family care, community care, and although this goes beyond simply caring for disease. We have also provided care for families from all the different steps, and family and community care also needed to be well organized. It is important for all players to participate. For instance, we have the COVID vaccination experience, regardless of the insurance and whether the people receive from the Ministry of Health or from private insurances, we are vaccinating throughout the country. We just base it on age groups and point of residence. This is how a model behaves when there is a crisis and can positively respond to incorporate all people, regardless of where they are or any other particular condition.
Finally, I would like to tell you that for us, the financing issue is also very important as far as coverage, access, universal health care, an allotment of resources efficiently, strengthening the health service in making sure that people receive quality care in a timely manner. Finally, the conclusion, we have to make what is invisible visible, make sure that nobody is left behind so that everybody can have a good life, even if they're outside. We need to empower citizens, and we must help everybody to participate, even if they have not done so in the past. Thank you so much. Thank you so much, Dr. Gustavo Rossell, for your presentation and for having shared Peru's experience. I am certain that this will be extremely useful for other countries as well, and we wish you the very best for the implementation of the program. It is a privilege for me to present Nurse Barbara Layton from the Undersecretariat of Health from the Ministry of Health of Chile. Thank you so much for the invitation. Hello to everybody. I will try to summarize in a brief presentation what our team is doing in Chile about course of life. Can you see? Yes. We have several public policies which are based on the population, and also they go hand in hand with other sectors. The course of life approach brings us to have policies that are integrated and make other elements of the state participate. And I will refer to public policies of course of life in different stages. As you know, we have a system to protect the young people, which has been internationally recognized because it is a great investment on young children, and this goes throughout the whole cycle. This goes from the young children throughout life, and how will this have positive repercussions on chronic health problems? We also have a policy which is called Choose to Live a Healthy Life, and this involves all the bodies of the state in order to see how we can give nutrition to people so that everybody may give healthy, nutritious food, and closing the access to food that can cause cancer. We're also introducing sport in the environment, in school, and at home. We also have a well-known law, which is the labels on food, so population can see what food they're choosing, whether it is high in calories or saturated fats and so forth. This has also been recognized because it is very important to reduce non-communicable diseases. This is a fundamental program in Chile. We not only examine it from the health point of view, this involves education, state institutions, the Ministry of Labor, in order to obtain the good coverage we have now. We have a 90% coverage in vaccination. This is extremely important. And as you know, the coverage that we have provided for COVID has been known internationally. We also have HES, which is a guarantee system. There are several diseases which are guaranteed to give access to health. So there is an access that gives people a timely care with dignity. All these elements are some of the laws that we have, and we also have another law, the law of tobacco. Nowadays, we can somehow ask whether people can go to work, to school, to restaurants without having to sit next to somebody who is smoking. So this protects non-smokers. I want to tell you about protection of children. Chile Grows with You, that's the name of the program. We have public policies which are state policies where the Education Ministry and the Ministry of Social Development, where from conception there are a series of elements which follow the development of children. Chile has invested a lot in the small children because we know that for each dollar that we invest for small children, we obtain benefits which amount to $8. So we take care of mothers, breastfeeding, and attention during birth, and also doing health checks on boys and girls. And this is happening nowadays very much all over the country. We also work on detecting risks and vulnerabilities in order to intervene before the risks in become a problem during the adult part of life. This is the trajectory of life course, mother-child life course. This starts with control of health in the population, for instance, prenatal controls and nutritional consultations, amongst others. All these policies, which I mentioned at the beginning, are across all aspects. We cannot have public policies if they are not part of the law and they do not have an assigned budget. So here there is a slide that includes some laws which have had repercussions on early childhood. For instance, it is compulsory to open K schools, increase postnatal vacations, and also give leave to men postnatal for men as well, and all other elements that help us guarantee the rights of boys and girls, and also providing advice on the health of girls and boys. You can look at it, it's all here on the slide. Some of the policies that Chile has had, which have had very important repercussions. Chile has been a pioneer. We created a consultative council where young people can directly be involved and bring their input in an intersectoral mechanism. And I want to state clearly that whatever has to do with the health of young people has had very healthy repercussions on fertility for children between 10 and 19 years. Where our goal was to reduce this rate by 10%, but we were able to go from 28.2 to 11.9%. How were we able to do it? By opening friendly spaces. We opened several centers in Chile, which gave an opening, and you can see this when there is a more highly higher coverage of these friendly spaces, the results have been better. We have to have a standard on information orientation on health issues, and we have also been able to open spaces for the young people so that they can obtain condoms without medical prescription. The Ministry of Education and Health worked together with the young people. At the national level, we have advisors in the entire country. They participate yearly in the preparation of policies. And I will give you the link for this in case you're interested. In case of the life of adult people, we are trying to generate a specific guarantee so that they can have preventive health tests, especially in the workplaces. So bring health to where the people are. So the focus is not on health, it is people. And taking into account the studies that have been carried out focusing on cardiovascular diseases. This year, the Ministry of Health of Chile launched a strategy of integrated health care within a context of multimorbidity, taking into account the risks that are at that group age, and this allows the help of the state in order to decrease the burden. This is not only at the workplace, but also taking into account the family environment. And this is extremely important to show our focus on life course for older adults. How do we create important links so that give right to older people so that they may not only be healthy but they can be functional? We need to support them so that they can have a development to give them autonomy. We have preventive health tests for adults, and also we have a national integrated plan for aging and an action plan. This was a very, very successful plan, and it involves all state bodies in order to focus on the health and social aspects of older adults. And I would like to state that in Chile, we are now adopting the ICOPE model, which is a social sanitary, social health model. It is involving people from the community, not necessarily for health professionals. It's not only vitality, visual and auditive capacity, but also the cognitive capacity and the possibility of helping improve the life quality of these people. And we are carrying this out in specialized institutions with primary health care. And the leader here is not the health department. Sometimes we have to make sure that the entire sector should take into account. For instance, economy, the Ministry of Economics or the Ministry of Education should participate in order to obtain better results. We have more than 50 specialists on this at the national level in order to be able to avoid intervention for older adults. In order to finish, I will tell you about some conclusions we have reached. we have very little time to tell you everything, but public policies which are focused on course of life must be centered in the territories in a decentralized way, focusing on the participation of citizens. The life course policies have to have a regulatory and legislative framework so as to have continuity and financial safety. It is necessary to continue education so that everything that is learned during early childhood should be transmitted throughout life. The most successful public policies and the most cost-effective ones are those that are centered on people. These are all the documents and all the web pages that you can use if you're interested. Thank you.
Thank you very much, Nurse Barbara Layton, for your presentation. We'd like to thank Dr. Gustavo Rossell and Nurse Barbara Layton for sharing their experiences from Peru and Chile. We congratulate you on your initiatives, and indeed a political decision is required. And as Dr. Enrique Vega pointed out, we realize decisions are needed from policy decision makers as well as budget areas. This is a collective effort, and it implies breaking paradigms because it can not only come from the health sector. And this is what we have seen through the comments from Chile and Peru. Thank you for your presentation, and let me hand back to Carolina to move on with the agenda. Thank you very much. Thank you, Amalia. Excellent panel. I'd now like to offer the floor to Dr. Andrés de Francisco, the director for this department, and he will be offering the closing remarks. Dr. de Francisco, please go ahead. Thank you very much, Carolina and colleagues. How interesting these presentations, so much diversity. And let me thank each and every one of you for your excellent interventions and presentations in this launch of the life course document. We had on average 300 participants. Sometimes it fluctuated upwards, sometimes downwards, but it shows how interesting this topic is and how relevant. I'd like to thank Dr. Frank Christopher Stanislao Anthony, Minister of Health of Guyana, for his words, as well as the representatives of the Ministries of Health, Dr. Rossell, the Health Vice Minister of Peru, and Nurse Barbara Layton, Health of the Life Cycle Department of the Chilean Health Undersecretariat, for sharing their experiences in applying the life course approach. These experiences in these countries, such as Guyana, Peru, and Chile, will be a benchmark for other countries who are currently contemplating incorporation of the life course approach to be able to help them along. Thank you to our colleague from WHO, Dr. Anju Banerjee, for his very valuable comments. Very important as we focus on using the life course. And it is particularly important based on his experience because he has worked so much in this approach of the life course. Thanks also Doctors Patricia Solis and Luque and Dr. Silva for their contributions today, but also everything they have done to assist in adopting this life course approach in the different health strategies. Colleagues, it is essential to link the principles of life course throughout our own work. As we have seen today in the different epidemiological trends and disease burden to understand what's happening in the different periods of the life course, even to determine timely actions and interventions that will allow us to intervene not only at the right moment, but furthermore to prepare early interventions. We heard, for instance, about the COVID-19 pandemic and how it is impacting services and quality of life. But I also believe it's important to understand that our response to the COVID-19 pandemic and future ones should be based on the life course principles that are presented in this document that we're launching today. When we spoke about building health, we're not simply working better to prevent and treat disease. We are ensuring the development of health capacities amongst people, and we understand that this capacity is a basic resource for human development and an essential component to generate human capital to guarantee the personal and social development of our countries. To ensure health path will ensure sustainable development. The development of our health systems, therefore, the delivery of health services and health protection, especially at the primary level of care, must take this approach into account. And as Dr. Barbosa, the Assistant Director, pointed out in his opening comments, it's fundamental for this document to help the public health work in our countries and promote multi-sectoral approaches that are people-centered. The resource must be turned into national and local actions to improve health and well-being for all at all ages. In closing, I'd like to invite you to visit the webpage of Life Course, where you will be able to access the publication available right now in Spanish, English, and Portuguese. In addition, you will find additional resources on this topic, videos, statistical information, and other useful material. Let me also invite you to a series of webinars to be held throughout this year, and you can see them on the screen now, I believe. And you will also be able to find them on our webpage in order to study in depth not only the issues that we've had an overview of today, but other important elements to promote our agenda of building health during the life course. I cannot close this webinar without first thanking everyone who contributed knowledge to develop the document and their work. This is the result of many years of experience in different health areas and coordinated efforts to incorporate relevant information that will be helpful to develop strategies to protect health and development at all ages. I'd like to thank Dr. Enrique Vega and the excellent technical team, as well as members of other PAHO departments who are present at this session, the Systems and Health Services, Non-Communicable Diseases, Evidence and Information for Health, and my own department, Family, Health Promotion, Life Course, as well as colleagues in countries who have supported us throughout the preparation of this document and now implementation of its principles. Let me furthermore say that it's worth recalling Dr. Manuel Peña. He was the inspiration and supported all these principles during his professional life. To all colleagues, everyone present, thank you for your support, and I wish you a good rest of the day. Goodbye.